Nick Palmcrit, floating vent guy. First YouTube live, which is nice. Going to do intro to mechanical ventilation. I get asked for this topic all the time, so I figured I'd go over it on a YouTube live. So we like to prevent death and torture if we can, especially with the mechanical ventilator, because it's sort of like what we set. So if we're setting it, we should set it with the intention to not torture or kill someone. So first, these are the objectives, just sort of overall, nothing sort of specific. So what are some indications for the vent, sort of an intro to settings. I'm not going to get into like driving pressure and optimal PEEP and all that kind of stuff. That's, for another time and for another lecture. Everyone always asks me for like an intro lecture, so I figured this would serve as that. And that way, if anyone ever needs an intro lecture, this can be something that you refer back to. And then how do we achieve the goals of oxygenation and ventilation safely, which is sort of how we teach the vent in that setting. So basics, what is mechanical ventilation? So you probably don't remember actually. In a time past, we had sort of the polio epidemics, and these things would spike. And then you might end up on an iron lung, which is what this guy's in. So ventilation has been around for quite some time, whether it was like in like ancient times or, how we sort of learned that you can sort of keep someone alive with ventilating them through their trachea. Where this sort of really took off was initially we had sort of the positive pressure ventilation, which people would come in with polio. And there's a book on this. I think it's called The Autumn Ghost, if I'm not mistaken, because that's when like polio would spike, and then kids would come in, they'd be super sick, they would essentially just drown in their secretions because they would sort of lose neuromuscular function, which is, horrible to see. But at some point, I believe in if I'm not mistaken, there was an anesthesiologist, I forget his name, is apparently it's like really crazy dude who, we had sort of the negative pressure, negative pressure breathing. At some point, we switched over to positive pressure breathing through a tracheal tube, through a tracheostomy, which was sort of this is the first time they did this in Copenhagen. It sort of like cut down the mortality rate from like 80% to like 30% overnight. So it's like this really sort of massive breakthrough that has a lot of historical context to it. And if you ever get a chance to sort of watch any lectures on it or read the book, super interesting. So we sort of go through in like the early 60s. At some point, so this is from History of Mechanical Ventilation. I think it's written by Slutsky. So, initially I think we didn't really understand the concept of like PEEP, we thought that large tidal volumes prevented atelectasis, which is where sort of anesthesia was coming from, as far as using large tidal volumes in the operating room. And we really didn't have like this thought of PEEP until much later. So as we sort of move through the timeline, 60s, 70s, 80s, 90s, 2000s, we go from not understanding like how big of a tidal volume to give, not understanding that sort of oxygen is toxic in of itself. So high amounts of FiO2 can be toxic to the lung. And then sort of the role of surfactant, and then the role of sort of the peak inspiratory pressure isn't the thing that's injurious to the lung. It's more of like the alveolar pressure or the descending pressure or the plateau pressure, not so much like the peak inspiratory pressure. And there was there was a study that sort of ventilated patients with like higher pressures and lower pressures and different tidal volumes and sort of 0 PEEP and 5 of PEEP and 10 of PEEP. And, what really injured the lung was sort of 0 of PEEP with like high tidal volumes, or, really high peak area pressures with really high tidal volumes and really high PEEP, which essentially just increases your alveolar pressure. We sort of roll through, and then at some point we get to large tidal volumes are bad. And certainly in ARDS, we should be aiming for smaller tidal volumes. And this idea of like the baby lung, where the size of the lung is now moved to the size of like a small child. So there's a lot of injured portions of the lung. It's heterogeneous. And what we should aim to ventilate is sort of the non-injured portions of the lung. And we should aim to ventilate those with smaller volumes. Because if we ventilate them with larger volumes or the same amount of volume as a normal lung, we're going to injure it. And that, the next frontier is certainly things like driving pressures, things like mechanical power. It's really figuring out how we can set PEEP with intention and not just sort of guess. So that's sort of, later down the line. So really simple indications for mechanical ventilation: hypoxemic respiratory failure. So we think of like type 1 respiratory failure, hypercapnic respiratory failure. So we think of type 2 respiratory failure, airway protection, excessive work of breathing, like working too hard, about to have collapse of the working too hard to breathe, not going to be able to sort of breathe on their own anymore. So you put them on the mechanical ventilator to help them breathe. Severe acid-base disturbances. So if they're super duper acidotic, they're going to need help sort of ventilating that off. And then obviously like procedurally, so in the operating room or other situations. So these are some indications for mechanical ventilation. The way that I like to think about ventilation is thinking about sort of these axioms. So these are sort of like rules that you should sort of go from. So we're not aiming for normal blood gas, right? We're aiming for something like a blood gas that's acceptable, but with pressures, so airway pressures and lung mechanics that are not harmful. Because ultimately, if we injure the lung with the ventilator through the settings, like that's an us problem because we set the ventilator up. So while we like to set PEEP with intention and set PEEP to what the patient needs based on the pathology, just sort of like cranking the PEEP isn't always the right thing to do. If you increase the PEEP, you're going to increase the alveolar pressure because PEEP is in the alveolar pressure equation. So if you set the baseline PEEP higher, then whenever you ventilate to, it's just going to be higher. If you're not recruiting lung, like recruiting atelectatic lung, let's say, then setting the PEEP just higher is just going to add to your alveolar distending pressure or your plateau pressure. So sort of the same thing. So we need to know like what's going on with the patient, what their pathophysiology is, and then setting the PEEP based on that. 6 cc's isn't inherently lung protective. I think I went over this like a few times, kind of most recently today. When we say lung protective strategy, lung protective ventilation, and Melody had a post on this recently. Remember, ARMA went, started at 8 and then sort of walked the total volume down if we could. And if they were at 6, then they got more and more acidotic, they would sort of like liberalize the total volume. Now that isn't always a great idea depending on what's happening with the patient, but it goes to show you that 6 in of itself isn't lung protective. It's definitely not lung protective if you're inducing a bunch of dysynchrony because the patient is very like flow starved or air hungry, which if we've decided that the patient needs 6 cc's per kg for whatever reason to limit the plateau pressure and they become incredibly dysynchronous, at that point in time, we're going to have to sedate, paralyze, sort of take over more so they tolerate the settings. Now, that's the risks. The benefits only outweigh the risks in ARDS. In every other pathology, it generally doesn't because we've never been able to show that 6 is any better than anything besides 12 in ARDS. So something like the PREVENT trial, so like 6 versus 10 in non-ARDS had no benefit. There's meta-analysis that sort of like point that lower total volume strategy might be beneficial. A lot of times these total volumes are like somewhere between 6 and 8 anyway. So inherently going 6 across the board for everyone isn't like the best idea. And it's probably not something that we should be something that we should be doing, I think, at least how I practice. And any questions you can always drop in the comments and sort of go over it. So don't feel like you just have to listen to me. Yeah. Oxygen is toxic. So going over, we think of like 60% is like this sort of where it gets like really toxic. There's some animal data, some human data that if you ventilate patients on 60% consistently for 24, 48 hours, they all get ARDS from sort of diffuse alveolar damage from free radical generation, et cetera. So we really like to take the FiO2 down as much as we can, as fast as we can by doing other things, setting the PEEP, proning, fixing other things that we can. So like, treating the pneumonia, giving diuretic, whatever it is. And then the last one, which unfortunately the box sort of cuts off, is that auto PEEP is never normal mechanics. So I've, interacted with some people that recently I think that don't sort of like respect auto PEEP as much maybe as I do. It's one of the things that I truly try to avoid if I can, because auto PEEP always leads to increased work of breathing. Auto PEEP always leads to, can lead to barotrauma, can lead to hemodynamic collapse, can lead to dysynchrony. So auto PEEP is never sort of normal. Now, we might not be able to take care of the auto PEEP sort of all the time or get rid of it completely, but it suffices to say that it never represents normal physiology. So that's just something that we need to accept. I wonder if I can go live on IG as well. That would be pretty sick. Let's see here. Okay. That's not what I wanted to do. All right. So moving on. So what are the goals? What are we talking about here? Like all this yapping. What are the goals here? So the goals are, we have goals of ventilation and goals of oxygenation. So goals of oxygenation. So we split them into goals of ventilation, goals of oxygenation. So goals of oxygenation are SpO2 88 to 92. So this is like a huge moving target, and is depending on what pathology the patient has, COPD, pulmonary hypertension. You might want to sort of further delineate, what your SpO2 goal is. There's a lot of literature that says sort of hyperoxia is bad. The way that Tobin thinks about this, which I think is interesting, is not sort of making your goal too high, because then if you're monitoring the O2 sat and it's too high, then and you're sort of like hyper oxygenating, you're not going to see the patient sort of like start to get hypoxic if you're pushing it high. So if it's a monitoring device, you would want to see it go from like 95 to 90, because then something's happening. If you're hyper oxygenating, it's like 100% and it goes to like 98%, even though it's a little bit of a change, you might not sort of pick it up as a monitoring device. So I thought that was pretty interesting when you brought that up. We shoot for FiO2 less than 60%, getting back to sort of this like animal data, maybe some human data, that over 60% is deleterious. And, certainly you want it to be as low as possible. And as the patient gets better, it should be lower and lower and lower. But we would shoot, if you notice on the servos, sort of, at least the servo U ventilator, if it goes above 60%, it sort of like changes color. It's like yellow or something, which is like letting you know that like, wow, this is like a lot higher. This is high. It's a lot of oxygen. And then adequate delivery of oxygen. So there's some oxygen dissolved in the blood that we sort of ignore. We want to make sure that the RBCs we have like enough RBCs, and then influencing the delivery of oxygen equation in such a way that we can, deliver enough oxygen to the tissues. So when we set the ventilator, we're setting the goals of oxygenation, or these are the goals of oxygenation that we're setting. So that's what we're trying to do. So the goals of ventilation get, I think, a little bit more, they get a little bit more interesting, because I sort of had like, a bit of like not a back and forth, but sort of a spirited discussion about the pH. So we don't set the vent for a PCO2 number or even like a blood gas per se, right? Like the blood gas is we look at it, we're, titrating the vent to get as close to normal as possible, but we should never be sacrificing good mechanics for a blood gas that's acceptable. So generally, most patients, we can tolerate this permissive hypercapnia strategy that is, a pH of like 7.2. In ARMA, they allowed the PCO2 to go up to like 80. Whether that's for every patient, it's going to be different, because some COPD patients it's not going to take much to get them to 80, right? Like they're already like sort of baseline, like around 60 or something. So them getting to 80 is not going to really be that big of a stretch. But when I set the ventilator, and I'll bring this up later in an example, I'm really just sort of going for like I go for above 7.2 certainly to start, and then if I can influence the circuit, if I can influence the ventilation more to get sort of as close to normal as possible, I'll do that. But I don't shoot for like 7.45. That's not sort of how I do things. And I've seen a lot of harm, I think, done with people trying to get to normal or as close to normal as possible, cause auto peep, and then maybe the gas is a little bit worse because auto peep sort of by definition creates more dead space. So then they, increase the rate more, and then you have more dead space, and then you're not ventilating as well, and then you're getting more and more auto peep. And so it can sort of like fall off the rails very easily. We shoot for plateau pressure less than 30, 28 if you're sort of like by the textbook. Driving pressure, I gotta say, driving pressure hasn't been shown in ARDS, right? So we were sort of, this was a discussion today, which was, we had a driving pressure of like 17 or something, and the patient was on the ventilator, and they were, they were sort of like, okay. But the point of the post today, if you saw it on March 31st, was that the patient wasn't triggering any breaths. So that's like sort of a problem when the patient's just riding the ventilator. So if you're set at 20 and the patient's breathing at 20, but not triggering any breaths, that's an issue, because that's going to lead to diaphragmatic dysfunction and ultimately more time on the ventilator. So while I think about driving pressure in normal ventilation, if the patient doesn't have ARDS, it's not really applicable, unfortunately. And I'm going to get probably a lot of heat for that, and that's fine. But that's sort of like the state of the evidence right now, is that's not really applicable at this point. Nonetheless, it's something that I do think about. Obviously, even if if the plateau pressure was like 25 and the PEEP was 5, that's a DP of 20. I would think to myself, why is that? Is there a compliance issue? Is the total volume too high, et cetera, et cetera? So, but ultimately we like to keep the plat like less than 30, less than 28, as low as possible, with a good enough driving pressure. But the example from today was, what I wanted to sort of get across was that the patient wasn't triggering any breaths, because otherwise the patient was triggering breaths, sort of ready for weaning and extubating, right? I mean, he was on like 40%. Everything else was normal. So we shouldn't be shooting for a normal gas, at least in my opinion. And we definitely shouldn't sacrifice any pulmonary mechanics to achieve some like normal gas, certainly in ARDS, certainly in like asthma and that kind of stuff. So we also like to shoot for no or minimal auto PEEP. The way that we teach the ventilator, we sort of like we really try to avoid auto PEEP at all costs. Sometimes we can't avoid it. It should be as low as possible. So if your vent isn't sort of set up for success and you still have auto PEEP, and you haven't done everything, so like gone up on the volume, decrease the rate, whatever else, maybe you're treating something like asthma or COPD or something. But we really try to avoid auto PEEP, or at least keep it to a minimum. So we have some goals of ventilation. We have some goals of oxygenation. So how are we going to set these things up? So now we have things that we set and things that we measure. So the things that we things that we set. So what are we setting when we start mechanical ventilation? And for all the IG Live people, I'll try to sort of, definitely don't want to see that. Just my mug. All right, so what do we set? So we're setting difficulty. This is why doing live stuff is so cool. All right, I don't think that's going to work. All right, maybe I just hold it. Might as well. Okay, what are we setting? So we're first setting the mode. So the first question with the mode is, thank you, Viren. The first question with the mode is, and this I took from a servo screen. So, what we're looking at is like the control, the interactive, which ignore because that has SimV on there, and SimV sucks, as we know, or the support. So support meaning pressure support, volume support, which is like sort of like AVAPs in a way, but with the breathing tube. So I don't really use volume support a lot of times. So the first question that you have to ask is like, do you want there to be a backup rate or not? So some rate that the vent's going to fire at. So if that's what you want, and if the patient just got intubated and they are still paralyzed, then you're going to want a backup rate, obviously, right? We're going to do some non-spontaneous modes. So we're going to do something like pressure control, volume control, PRVC, which sucks, as we know. And we definitely don't want to do SimV, but SimV would be another sort of like thing that we could do, which we would never do. But if we wanted to do it, we could. So the first question you have to ask is, do you want a backup rate? If you want a backup rate, then that means you're going to start with some control mode. So that'll be AC, so assist control. The patient has a controlled breath rate, let's say 15. And then the assist portion is they can trigger breaths. And if they trigger breaths, they're going to get that same breath architecture. So pressure control, volume control, PRVC. That's how that sort of works. Okay. So the next thing is if you're going to do spontaneous, so pressure support, then you're going to have to set some pressure support number. So PS of 10, PS of 15, PS of 8, some number. And then a cycling threshold, which is going to be a little bit too confusing, I think, for this talk, because I'm trying to keep it super simple. If you're doing a non-spontaneous mode, it's like a control mode. So you're going to either set pressure control, PRVC, or volume control. Pressure control, the pressure is set, the volume is variable. So pressure is set, volume is variable. Volume control, the volume is set and the pressure is variable. Volume target, much to people's surprise, is a pressure controlled mode, but we're asking the vent to get some volume. So it's a pressure controlled mode because the flow is not fixed. So if the patient takes a tremendous breath in, then they're going to get more flow, more volume. And so that's one of the reasons why it's pressure controlled. The other reason why is that the volume is not fixed. The third reason why is that during the inspiratory time, the pressure doesn't change. It's sort of whatever the vent decides it should be. So that's why PRVC, volume targeted, these are pressure control modes. So you have to sort of pick. So if you want to, and they're all sort of the same if you know what you're doing with them and set them with intention. So If you pick volume control, pressure control, whatever you want to do. So first question, are you picking a controlled or spontaneous mode? So spontaneous or non-spontaneous. Second question is, what's the breath type going to be? Is it going to be, if it's non-spontaneous, is it going to be pressure control, volume control, PRVC? The next thing you have to figure out are like, what are you going to influence to achieve the goals of oxygenation and the goals of ventilation? So what can you influence on the ventilator to achieve the goals of oxygenation, the goals of ventilation? So with the goals of oxygenation, you can influence the FiO2 and you can influence the PEEP. With the goals of ventilation, you can influence the tidal volume or the rate. So remember, FiO2, you can set it to 100% sort of initially if you want to, but remember, we like to keep it under 60% if we can. If we can't do that, we're going to start using some PEEP or do other things to recruit lung to be involved in gas exchange and then be able to come down off the FiO2. PEEP, we're going to set with some intention if we need to. We generally start somewhere between 5 and 8, sort of as like a jumping off point, and then titrate from there. With the total volume, I usually start somewhere between 7-ish cc's per kg. We've gone over this ad nauseum that there's no benefit for 6 in all comers. It leads to sort of desynchrony, air hunger, et cetera. So out of the gate, I usually start around 7. And then if I need to step it down, then I step it down. And then a rate, we want to pick a sort of a rate that achieves some minute ventilation. And depending if the patient has a need for a higher minute ventilation, so metabolic acidosis or something else, you might want to pick a higher rate, but you have to be careful that you're not going to induce auto PEEP. So that's one thing that you need to be cognizant of. So how we influence these things. So oxygenation, the only way you can really influence it per se is with your PEEP. Now you can increase the FiO2 to 100%, sure, but you'd want to get off that because remember, oxygen is toxic. So how do we do that? If we're on 5 of PEEP at 100% and there's a bunch of atelectasis, we're going to have to increase the PEEP and or treat the atelectasis. So that's how we sort of get off of it. Total volume, depending on where you are or where you work, some places start with 7 cc's, some places start with 8 cc's. I usually like to start with somewhere between and then work my way down if I need to, if I think that if the plateau pressure is higher than I would want it to be or something of that sort. If your rate, so you need to set your rate not so high that you cause auto PEEP. Now, we can figure out that number that's going to cause auto PEEP. That's sort of this idea of the time constant that I've gone over before. I think most of the time we just sort of set it somewhere between, 12, between 12 and 20. Most people wind up on something like a rate of 15 or a rate of 16 or a rate of 18, something in that range. If the patient's really acidotic and I think that they need to, and they need more minute ventilation, I'll go up to something like 20. But even with normal lungs, I mean, it gets really hard to go above 20 without causing auto PEEP because remember, exhalation on the vent is passive if you're paralyzed. So you sort of inflate the lung and then the elastic properties get you back to FRC. So you take a breath in, and then from that kinetic energy that you store, or that potential energy that you store when you sort of stretch all those muscles and tendons and stuff out, and when you take that pressure away, everything sort of contracts back down, the air moves out. The problem is there's going to be some rate that's going to be too fast, and that's going to cause auto PEEP if the patient's not participating in exhalation. So getting above 20 gets really difficult if you have sort of normal lungs. But if you intubate someone and they have metabolic acidosis, the best way you're going to sort of, get their acidosis sort of breathe down as much as you can is having them involved in breathing. And they're probably going to take big tidal volumes and they're probably going to be breathing quickly. They're probably going to get auto PEEP anyway. You're not going to be able to do anything about that. But the point is, you're going to have to fix the underlying condition. And fixing anything with metabolic acidosis with the ventilator. So if someone has DKA and they somehow get intubated, you're not fixing the DKA with the vent, right? You're just sort of bridging them to fix their DKA and then get them off the ventilator. So that sort of would be the idea. Okay, so what are we measuring after we set up the ventilator? We're going to have things that we set, then we want to measure stuff to make sure we're being safe. So blood gas, you're going to peripheral sat, your physical exam. End tidal, I threw that in there just to sort of placate everyone that likes end tidal because I hate end tidal personally. That's because I'm in the hospital, but I know in the pre-hospital and intra-hospital setting, it's super important. And then safety-wise, you have plateau pressure, auto PEEP. Peak airway pressure, I didn't put in there initially, only because it's not something that I sort of look at. If the peak is 50, that probably, and the plateau is normal, and you're in volume control, that probably has more to do with the pathology, right? But something, and again, we don't really like, not that I'm not going to say that we don't care about the peak air pressure, because we do, but it's not something that I check, sort of like out of the gate. But you certainly could, and it's certainly something to pay attention to. But I didn't put it in there because, I mean, maybe, and when I sort of update the slides, I'll probably throw it in there with little asterisks. But the safety things I really want you to be concerned about are making sure the plateau pressure is good or within range or in a safe range, and making sure there's no auto peep. So if we were going to set up volume control, imagine this is a case, 64-year-old dude, hypertension, diabetes, et cetera, blah, blah. He comes in, he's got a right sort of probably lower lobe pneumonia because it doesn't obscure the right heart. So it's sort of like not right middle, probably like right lower. And he gets intubated, and the initial gas is like 729, PCO2 is 68, and PO2 is 58. And then, we intubate the patient. And then if you're sort of like the resident or the intern or even the fellow, the attending, the APP, the nurse, whoever, or if you're RT yourself, and of course the attending sort of intubates and just walks out of the room and doesn't tell you what to set. What are we going to set on the ventilator? Like, how are we going to set this up? So we're going to think about our goals of oxygenation and ventilation. So if we're going to go with volume control, we're going to need to set a rate. We want to think globally about the minute ventilation. I don't think about the minute ventilation in the sense like I'm trying to achieve some number. You certainly, I do think about that if the patient's breathing very fast. After we intubate them, I'm like, oh boy, they were breathing, 40 times a minute. They probably had a high minute ventilation. I better, I'm not going to put them on a rate of 12, right? I'm going to put them on sort of a higher rate. What that is, I don't know. 15, 18, like I said, 20, something like that. So, a lot of times when I set the rate, it's mostly like vibes set a lot of times. Total volume, because ultimately you're going to have to put your chips down on a volume. You could start somewhere between, I think I put between 6 and 8. I usually start at like 7 most of the time, and then either work my way up or down depending, because if the patient has COPD, oftentimes you have to end up on higher volumes. So like 8 or 9 cc's per kg, let's say, right? And lower rates. If the patient looks like they're going to go into ARDS, or they're sort of, they're already in ARDS maybe, right? They had pneumonia and now you intubate them and the plateau pressure is 40. I'm going to have to, I could start at 7. We're going to have to work my way down. But, the initial settings, we go somewhere between 6 and 8. I usually go about 7. That should still be ideal body weight. Where I work now, where I've worked before, and even in residency, like we break out the tape measure and measure people. I think that's what you should be doing if you're doing good ventilation or doing it safely, at least. Like you shouldn't, when you're in the ED, it's different, right? You didn't like things are popping off, and it's kind of hard to get the tape measure so we can measure the patient. But and not saying you have to do that initially, but at some point you should get a height on the patient. Just like you should get a weight on the patient, just like not when they roll in the ED, you say, oh, it's probably like 100 kgs, give me like 100 of ketamine or something, right? Like we should be like weighing these patients at one point. And getting a height on them. So I always get, where I'm at now and where I was before, we get a ruler and we measure them tip to toe, and we get a height and we put it into Cerner or Epic or whatever, and it spits out an ideal body weight. And then, off of that ideal body weight, I figure out what's like 6 or 7 cc's per kg. I usually go like 7, and then I work my way up or down if I need to. Me personally, I start at a FiO2 of 100%. The patient just got intubated, like it's popping off. I just get them at 100 and then come down instead of trying to like perfect is the enemy of good in this situation. I think so. If the patient was like hypoxic before and you sort of got them through the intubation and all this other stuff, I just leave it at 100 and then I titrate it down once I get the gas back. And then, a PEEP. So started a PEEP somewhere between 5 and 8. I've worked at all kinds of different places that some start at 5, some start at 6, some start at 8. I usually start somewhere between 5 and 8. And then depending on what I need to do, I either, go up or down on the PEEP. So this is not a vent. It's from a sim, ventsim.cc or something. It's a really good website for simulation of mechanical ventilation. So, we got volume control. We have a rate of 15. We have a total volume of 450, which is about 7 cc's per kg. The FiO2 is 100%. The PEEP is 5. We get a gas in like 30 minutes. It's all made up, 30 minutes, 45 minutes, an hour, whatever you want. And then so we're at, 736, 53, 350, 24. So we have a little bit of respiratory acidosis, right? So there's no metabolic component. His PaO2 is very, very good. It's 350. So it could certainly come down off of the FiO2. Should people be ashamed? So comment from IG, should people be ashamed for using 7.5 of PEEP? Yes, we should always shame people for using half of PEEP. No, I'm kidding. You can use whatever PEEP your heart desires. Some people get really pissed when you use odd numbers. Like PEEP only exists in like 5, 8, 10, or 12. So if you put the PEEP on 7 or 9, like people freak out, which I think is funny. But so this gets to a larger meta point, which is I want the patients to trigger all their breaths. So, would I do anything with this gas? I personally wouldn't do anything with this gas because once our paralytic wears off, the patient's going to wake up and they're going to breathe because they're a little hypercapnic. And remember, hypercapnia is a tremendous drive to breathe. Tremendous. Much more of a drive to breathe than hypoxemia. Okay. So a little bit of hypercapnia is a tremendous drive to breathe. So why that's important is when we talk about worker breathing on the ventilator, you want, if the patient's sick, like you want the vent to do most of the work, but you don't want the vent to do all of the work because then you induce diaphragmatic dysfunction. Diaphragmatic dysfunction increases your time on the ventilator. It makes weaning more difficult. I think there's increased mortality. So all this bad stuff. So I want the patients to do at least the trigger work. So the worker breathing to trigger the ventilator. So 736, like for me, it hits the goals of, so our goals of oxygenation are good, right? We're going to come down off that 100%. The PaO2 is good. Their peripheral oxygenation is good. And we're delivering oxygen adequately. I personally would leave the rate and the volume, and I would wait till the paralytic wears off. Then the patient would wake up and breathe, and then they would sort of set their own pH. I try not to fiddle faddle too much with the pH in the patient's brain because you're always going to sort of lose, if they're alkalotic or if they're acidotic, you can only sort of do so much. So I let the patient control that piece of it. So they're going to wake up, they're going to start breathing. If they're breathing like 16 and I see that they're breathing and, the rate is at 15, so it's like right in the way of them, I'll take that rate down to like 13 or 12 to get the vent out of the way. That way, the patient's breathing, they're doing the trigger work on their own, at least sort of protecting their diaphragm. That being said, you need to make sure that the patient's doing not a lot of work, because if you want the ventilator to do the work of breathing because they have pneumonia or whatever it is, then you don't want them to do like most of the work of breathing, right? So it's sort of this like trade-off, but I want the patient to do the least of work of breathing. Okay, so me personally, I would leave it 736, 53. I would leave it. There's people that would, increase the rate, increase the volume, and then and then the gas is perfect next time. But remember, we're not like sort of going for perfect gas. We're going for acceptable with good mechanics. So for me, this is acceptable with good mechanics, and I want the patient to do the trigger work, like that portion of the work of breathing. So I would leave it personally. I could see how other people wouldn't. They would want it, they have, by definition, the patient has like some respiratory acidosis, and that's because of our settings. But I would leave it myself. Okay, so fine tune the settings is sort of like what I was talking about. We can, go up on the rate, you want to go up on the volume a little bit. We're going to come down the FiO2. I think the PEEP5 is fine. And, if you saw waveforms like this, like these are normal. So I wouldn't be too concerned about that. The one thing I wanted to throw in was that, we need to be really cognizant of, if you just snap your fingers, you make the total volume 60 Cs per kg and the patient has like some reason to breathe tremendously, you're going to cause dysynchrony. You're going to probably cause a flow dysynchrony. The patient's going to get more agitated. They're going to get more medication and sedation, etc. And it's going to like just sort of spiral out of control. So we have a question from IG. Why do you dislike PRVC and end tidal monitoring in a nutshell? Okay, so PRVC, table that for now because I'll talk about that when we get to PRVC and like do PC next and PRVC. End tidal, I'm really just being facetious. Me personally, I'm in the hospital. It doesn't really move my needle in any direction. But that's because, if I had a real question about it, I would get a gas, number one. Number two is, it's like this numeracy bias. So just because you have a number to something, and it's like red, that means that you got to do something about it. And then a lot of times we just harm people and we harm people or cause like more unintentional sort of iatrogenesis, trying to make the number not red anymore. There's a great article by Rick Pescator that Melody and the pre-hospitalists did this like really great end title post like maybe a month ago. And then I shared it with her, which then she shared it. It's called I think it's called like end title, The Number That Cried Wolf or something. So he goes over like in tremendous detail, like, the end total is 37, right? But like, what does that mean if the patient's breathing like 50 times a minute? Like, did I need that? Melody always says that And I do, I agree with the fact that like, yeah. So respirologist, we're going to get the PRVC. Don't worry. We're going to elucidate that tremendously. I just don't know for me in the hospital how much it's helpful. I can see if you're transporting a patient, it's definitely helpful if you don't have access to like an eye staff for a blood gas. Number one. Number two is if you're transporting a patient, and this is like intra-hospital and pre-hospital stuff. Not that I'm like a pre-hospital guy, but I'm talking Melody enough. It's another way that you can tell if the patient's still air trapping, right? So if your end tidal doesn't plateau, if you have that shark fin, then that by definition means that you haven't sort of plateaued your PCO2. So if you start another breath, you're air trapping by definition. So I think it's helpful in that situation. Again, I'm in the hospital with different ventilators that I can do different things. So it's mostly facetious. I do worry that we attach numbers to things a lot more, and then like we do stuff just to make the number look better. And I don't know how much like it really helps in the long run. But to each their own. If you're using it and it's like helpful to your practice, like go for it. But it gets to this like bigger logical fallacy of like not numeracy bias. It's a quantification bias. So just because you can quantify something doesn't necessarily mean that like you can intervene on it that's going to do anything that's like worthwhile. All right. So pressure control, my favorite at least. So same case, same situation, same sitch as the kids call. Remember, in volume control, we're picking a volume, and then your pressure is going to be your independent variable. It's going to go up if it needs to go up to sort of deliver the volume. In pressure control, it's the opposite. So your pressure it won't change, and your volume and flow will change. So that's your independent variable. So if your resistance goes up, if your compliance goes down or up, if your PEEP goes up, if the PMUS or how much the patient's like interacting with the circuit goes up, your volume will change. So if the patient's passive, then that's not going to be something so if the patient's passive, the volume you generate isn't going to have anything sort of to do with the patient in of themselves. It's going to have more to do with the delta pressure you set and then the pulmonary mechanics. So same thing, if you have pressure control, I still start at a rate between 12 and 20, depending on like what's going on, sort of like the pre-intubation pH or the pre-intubation vibes or whatever. Most people land on a rate of like somewhere between 15 and 18, which I think is fine until you sort of figure it out from there. Your delta pressure, so like your inspiratory pressure, some people call that your driving pressure, was a little bit of a misnomer. It's confusing. So I usually start somewhere between 10 and 15. So you have like 5 at PEEP, and then you have inspiratory pressure of 15. That gives you total pressure of 20. So 5, 15, total is 20. So your peak airway pressure is 20 because it's 5 plus 15. With if you have a non-compliant lung, like if they have bad ARDS or they have like edema or something, you're going to need a bigger driving pressure, a bigger inspiratory pressure, a bigger delta pressure to set up a gradient for flow and then ultimately total volume. So that's something to think about. So, if you put the delta P at 12 and the total volume is like 200, guess what? You're going to need more delta P, right? Okay. So it's going to depend on the mechanics you see. Normally, if you do, 10, 15, like 20 would be a lot of delta P, just as like a 30,000 foot view. But the volume you generate is going to be based on, your delta P. So a higher delta P for any mechanics is going to give you a bigger volume. But if you have some delta P, if you have like 12 or 15 and you get some volume, the volume you get is going to be based on essentially a few things. One is the resistance. So if you have like high resistance, you're going to need a bigger delta P to get the same volume. Next is compliance. So if your compliance goes down, ARDS, you're going to need a bigger delta P to get that same volume that you had normally. And then total PEEP. So total PEEP is important because if you have auto PEEP in pressure control, that manifests as lower volume, because if you had some volume and you had 5 of PEEP and then 15 of inspiratory pressure, but now you have 5 of PEEP that you set, but now there's 5 of auto PEEP. So instead of going from 5 to 20, so like delta of 15, now you're going from 10 to 20, so delta of 10. So your volume is going to go down ultimately. So which is sort of like my argument for not using pressure control with asthma, unless you're like really paying attention, is that your volumes could drop off, and if you don't set your alarms tight enough, no one might recognize it, right? So you can have a volume of like, 500 with a delta P of 15. And if the patient gets like more bronchospastic, that delta P of 15 is only going to get you 400 now. So your minute ventilation is going to fall off. If your minute ventilation falls off and your alarms aren't tight, meaning, your minute ventilation went from like 5 to 3.1, but the vent would alarm if it was at 3, then your vent's not going to alarm. If nobody notices it, then the patient could be hypoventilated, right? Especially if they're paralyzed. So when you're setting up pressure control, you're going to set a rate, then you're going to set some inspiratory pressure, 10, 12, 15. You're going to set a PEEP. You're going to set an FiO2. I usually start at 100. And then also with pressure control, which I think RT normally just sets, but you can set it, is an inspiratory time. Because in pressure control, how the ventilator knows to go from inspiration to expiration, the cycling mechanism is the inspiratory time. Okay. So we set that. Our team normally sets it somewhere between, like 0.7 to 1 second or something. I usually just set it 1 second because it's easier to do the math if I do a time constant calculation. So that's ultimately going to be your settings. So you're going to be like pressure control, rate of 15, inspiratory pressure at 10, FiO2 is 100%, PEEP is 5. With that delta pressure, you're going to get a total volume of 450, which is like 7 cc's per kg. If you set a delta pressure of 15, or sorry, in this example I used, it was 10. So inspiratory pressure is 10. And that got me a volume of 450. If our inspiratory pressure was 10 and that only got me a volume of 250, guess what? That volume's too small. How are you going to influence the circuit to get a bigger volume? You're going to have to go up on the inspiratory pressure. So you're going to have to go to inspiratory pressure of like 20 or something, right? And you're going to get a bigger volume. Now that has downstream ramifications because if like depending on the mechanics, you would sort of have to figure out like what's your driving pressure, right? So if you needed an inspiratory pressure at 20 to get a volume of like 450 and you're starting at a PEEP of 5, theoretically your plateau pressure would be something like 25, right? Like 20 plus 5 is 25. If you wanted to get your driving pressure, that would be 25 minus 5, which is 20, which is a little bit higher. So, in pressure control, the way that you influence, if the patient's paralyzed, the way that you influence the volume is by going up on the inspiratory pressure. If all things are the same, an inspiratory pressure of 10 versus 15 versus 20, the higher you go, the bigger volume you're going to get because the bigger your delta. So same thing, the gas is the same. It's 736, 53, 350, 24. Again, I would leave it where it's at. I would leave it where it's at because the patient's going to get unparalyzed at some point. And then theoretically, if we were, practicing like at the top of our game, we would, not have them sedated like out of the gate, right? We would want to like interact with them and like see how they're doing. Are they in pain, etc. That's like a whole nother topic for discussion. Ultimately, you would want them breathing on their own. So I would personally leave 73653 because when they woke up and they were unparalyzed, they would start triggering breaths and then they would sort of like set their own respiratory rate and do the triggering work, which would avoid diaphragmatic dysfunction, etc. So that's just me. I think most people would like increase the rate or the delta P to sort of make the gas perfect. Again, the way that like we approach it is not perfect gas, but like acceptable gas with really good mechanics. And we talked about fine tuning, so you can increase the rate if you wanted to. You got to be careful not to induce auto PEEP. So, if the patient was like, and you have to test, right? So if you were on a rate of 15 and there's no auto PEEP and you went to a rate of 18 to make, the gas better, and now there is auto PEEP, like I would go back to the rate of 15, right? I wouldn't leave it at 18 because you're getting auto PEEP at that. Remember, auto PEEP never represents normal mechanics. Okay. That's like the approach that I take. All right. So PRVC. Okay. Same situation. All right. So PRVC, what's the problem with PRVC? The problem with PRVC is that PRVC is a pressure mode. PRVC, the flow is unfixed. PRVC, it's targeting a volume that you set. So the way that it targets the volume that you set is in the first couple breaths, it acts as like volume control and figures out the plateau pressure. Based on that number, the vent will then set the plateau pressure as the inspiratory pressure in subsequent breaths. Okay. Because the vent thinks like the compliance is X. And if the operator, meaning us, wants a volume of 500, and the plateau pressure when the vent does volume control and it gives a volume control breath of 500, if the plateau pressure is 20, that must mean that we only need, if we're doing 5 of PEEP, that we only need 15 centimeters of water of inspiratory pressure to achieve that volume. That's how the ventilator thinks. That's the algorithm. The problem is so this is from the handbook from getting, I don't know how you say it. So the first breath, like couple breaths are like test breaths. So it figures out what the plateau pressure is. Then the subsequent breaths, the inspiratory pressure is the plateau pressure that it tested before. The problem with PRVC is that if you set a volume of 500, okay, and remember the flow is not fixed. So if the patient sucks down hard on the tube and gets more flow and volume, the vent's going to see that. And it's going to see that instead of giving a volume of 500, it gave a volume of 550. So the vent's going to think to itself, wow, I am overshooting my target with 15 centimeters of water. I should decrease the support on the next breath because I don't want to overshoot. So what that turns into is if the patient has a high work of breathing, the support from the ventilator goes down and down and down because the work is being done by the patient. Okay. If you intubated the patient because they had a high work of breathing, I wouldn't put them on a mode that decreases the support as the work of breathing goes up. That'd be like counterintuitive. Furthermore, PRVC's claim to fame is that it's like less peak area pressure or something. If you look at like the studies that they said that, where it's like, remember peak area pressure is sort of irrelevant too. Like it doesn't really matter. Like what really matters is auto peak, plateau pressure. So peak area pressures, if you want to say PRVC gives you a peak area pressure of 24 and volume control gives you a peak area pressure of 20, there's nothing saying that has any clinically meaningful outcome, right? Doesn't decrease mortality, it doesn't do anything. There's real harm with PRVC and other adaptive modes because as the work of breathing increases, the support decreases. Notwithstanding, the one study I think that came from, they used volume control, but they used constant flow. The difference between volume control with decelerating flow and volume control with constant flow is that when you have constant flow, there's always a contribution of the resistive portion of the lung in the peak area pressure. When you have decelerating flow, as the flow decelerates, the contribution from the proportion of the peak area pressure that's from the resistive portion goes down. What I'm trying to say is that if you have PRVC, volume control square waveform, and volume control decelerating waveform, your peak area pressure with PRVC and volume control decelerating waveform is almost the same if all your mechanics are the same, because the math works out. Because in both of those situations, theoretically, your flow goes to zero. So just mathematically, your peak area pressure is going to be almost the same. And if you don't believe me, you can go to a ventilator sim and do it and see what the peak is. If you have constant flow, because there's always a contribution from the resistive portion of the pressure to the peak area pressure, your peak area pressure is always going to be a little bit higher because there's always going to be a little bit more pressure coming from the resistive portion because you always have flow. But that doesn't mean anything. That doesn't mean that, a difference of 4 centimeters of water or peak area pressure does anything. It doesn't decrease mortality. It doesn't do anything, right? There's a real harm with PRVC and other adaptive modes because as the work of breathing goes up, the support from the ventilator goes down. And 9 times out of 10, no one could recognize that. So what I see is patients being tortured on the ventilator. Remember from the first slide that Instagram Live can't see, because the first slide said we should prevent death and torture, right? We should avoid death and torture with the mechanical ventilator. That would be sort of like the first thing we should do. And the way that we torture people most of the time is with our settings because we don't understand the ventilator. And that's what we're trying to do here. So same thing with PRVC. We're going to set it up as volume control, even though it's not. It's pressure control. You're going to pick a volume. The vent's going to do some test breaths. It's going to see what kind of pressure it needs to get that breath. And then from there, it will, either up or down titrate the pressure to achieve the volume that you wanted to achieve. Okay. So the changes on the vent, they get a lot more complex, honestly, with PRVC. So if you have auto PEEP, let's say, it changes because auto PEEP by definition decreases your compliance. So if you have auto PEEP, and let's say the patient's not breathing, in subsequent breaths, your volume is going to go down because we talked about that, right? We talked about since it's a pressure controlled mode, it's going from a PEEP to a peak inspiratory pressure during the inspiratory time. But if you have auto PEEP, you're starting at a higher PEEP. Instead of 5, you're starting at 10. So on that breath cycle, the vent's going to deliver less volume. So on the subsequent breath cycles, it's going to step the pressure up over time. Now, what does that mean? It doesn't mean anything except for the pressure is going to be higher. I personally like volume control if I'm worried about auto PEEP because I can see on the vent as it's happening in the in-story time that the pressure is going up. And then depending on if it's sort of like, on one side of the pressure curve or on the other side of the pressure curve, if it's sort of on like the left shoulder of the pressure curve, that can mean that there's a flow volume, there's a flow resistance issue. So if someone has asthma and I see that their peak area pressure is really high in the beginning and then it sort of comes down, I might think to myself, man, maybe their resistance is much worse for some reason. Maybe they have a pneumothorax, right? With PRVC, and stay with PRVC for a second, if you had a pneumothorax like right now and you were on PRVC, you wouldn't see the change in the pressure curve until a couple breaths later, right? Like, and whether that matters, I don't know if it matters or not. But for me, if you have a pneumothorax right now with volume control, in the next breath, it's going to need more pressure to get your volume in. And I want to know when there's things wrong sort of right away on the vent. So that's sort of how I approach it. All right, we talked about that. So initially PRVC sort of is volume control because it does some test breaths and it figures out what the plateau pressure is. Then it uses that plateau pressure as the pressure that's going to pressurize to in the subsequent breaths to deliver your total volume. Don't get me wrong. If you have like a Meemaw and she's like paralyzed or whatever, and you want to do PRVC, be my guest. But if you have a patient that's like dynamic or sick or has ARDS or is breathing or has even worse metabolic acidosis, PRVC is like not a good mode to be on. And most people don't understand that, honestly. And so remember, PRVC, since it's a pressure-based mode, your vent waveforms are going to look like pressure control, meaning your pressure is going to be sort of this flat top. It's not going to change in story time. And your flow curve, it's not going to be a straight line down like in volume control with a decelerating ramp. It's going to be sort of this like natural decay situation. Okay. And this can change, right? If the patient sucks down hard, they can get more flow. So the flow is an unfixed variable, which makes it pressure control. I don't know. Again, I wouldn't sort of fine tune the settings. The patient's going to wake up and start breathing. I want them to do the trigger work. I'm going to decrease the rate so they are triggering every breath because I want them to do at least that much work. Ideally, they would only do that amount of work and then they would sort of like ride the vent through and let the vent do the work for like the breathing cycle. But I want them to do the trigger work because if they don't do any of the work of breathing and they don't do the trigger work, then their diaphragm is truly resting. Remember, even though some of you guys are going to get off this call and be like, we're going to put the patient on PRVC overnight to rest them. You don't want the patient to rest truly because rest, like true rest, meaning like I'm not breathing, I'm not using my muscles at all. The diaphragm gets dysfunctional very, very quickly, like 12 hours. It starts to show signs of dysfunction. So you want them to be doing the work, some of the work of breathing. Okay, so we're going to do safety checks, right? So we're going to check our plateau pressure. We're going to check our auto PEEP. So plateau pressure is the pressure after you put in a total volume. So what you're going to do is, and I'll do it on this because it's easier. Because I didn't have it there. So yeah, for sure. So for plateau pressure, we're going to press the inspiratory hold button. We're going to press this thing. It's going to boop, right? And then what you're going to see is you're going to see this. It's going to sort of hold the flow after the total volume goes in. The flow is going to be held at 0. The vent is going to sense the pressure in the circuit. The pressure in the circuit is a surrogate for the alveolar pressure downstream. Is it perfect? No. Is it what we have? Yes. So you're going to press the inspiratory hold button. Sadly, like the pre-hospital, intra-hospital vents like the T1, the Zoll, and all these things, these vents don't have a floating valve or something, so you can't do the hold. So you have to, like, the vent calculates the plateau pressure, but if the patient's breathing, it's like not accurate 100% of the time, blah, blah. But if you have a vent that can do a inspiratory hold, what it does is press hold, flow goes to 0. The vent senses the pressure in the circuit after you put in a total volume. That pressure is the plateau pressure. We want that number to be less than 30, less than 28. And on the servos, at least, it'll spit that out right here. So on this one, when I checked it, it was 18, the plateau pressure. Similarly, for auto PEEP, you're going to press the expiratory hold button. When you press the expiratory hold button, after expiration, it's going to hold the flow at 0. So here, the vent's going to sense the pressure in the circuit, and then that's your total PEEP. Now, 5 is our set PEEP, right? And then your total PEEP is up here on the servo, at least. The Puritan Bennett and stuff in Hamilton's like all different. So you have to, if you're somewhere and you don't have servos and you have Puritan Bennett's, just ask RT or someone else to show you like where all this stuff is. But it's going to give you total PEEP. To get auto PEEP, you subtract your total PEEP minus our set PEEP. Whatever that difference is, your intrinsic PEEP, your auto PEEP. There's a lot of numbers for this. My practice, my belief, there's like not like some big RCT on this, right? There's like this, there's not a lot of like evidence on mechanical ventilation to begin with, but like auto PEEP and stuff, certainly. Like I said before, auto PEEP never represents normal mechanics. If you have auto PEEP, the way that we teach it at least is that you should change your settings to alleviate the auto PEEP sort of at all costs. Now, if the patient has like asthma or COPD and you've done everything and you can't sort of like get rid of the auto PEEP because of the mechanics, then that's one thing. But like we said earlier, if your gas is like 735 and your rate is like 16, don't make the rate 22, make the gas normal, but do that at the expense of auto PEEP. Okay. Like that's not what you should be doing. At least that's what I think. And I guess your attendings or whoever can disagree, but auto PEEP does nothing but bad stuff. It increases the work of breathing and makes the patients uncomfortable. It can lead to barotrauma, it can lead to hemodynamic collapse, et cetera, et cetera. So there's no amount of auto PEEP I think that's safe. That's sort of like my hard line. Obviously, I've been in situations where there's one or two of auto PEEP and I just sort of like accept it. But you should be aiming to not have any auto PEEP. I think that's like a good goal to have. So this is like almost the last slide. So how to talk about this stuff on rounds. So, the way that rounds, or if you're giving a report or whatever, I think the way that you should do it is, give what we set and then like what we measure, because what we set is sort of like what we have the patient on. Then what we're measuring essentially is like hitting our goals of oxygenation, ventilation, and then safety. So the patient's on ACVC, the set rate's 18, the volume is 500, the FI2 is 50%, the PEEP is 5. With those settings, we're getting a peak area pressure of 25, a plateau pressure of 22. The actual respiratory rate is 20. And there's no auto PEEP. Giving the actual respiratory rate is important because, if you say that they're on ACVC, the rate is 15, but you don't tell me like the actual rate, and I look at the vent and the actual rate's like 40, like that's a big difference, right? That's something that, we need to address. So we have what we set, we have what we measure, we have our safety stuff. So we're hitting all our goals, we're safe. And then on these settings, the gas is, 7, 4, 47, 200, and the bicarb is like 20 or something, right? And then you can sort of like pare down from there. But that's how I ask the interns and residents to like report the settings, sort of like what we set, what we measure, and then what we're getting with our settings. The patient has ARDS, then we get into more things like, what's your driving pressure? If I really want to torture them, I'll ask them what the mechanical power is and all that kind of stuff. Okay, so I just put this in here for like language stuff because I don't know, do we ever really talk about like the definitions of all this stuff that we're talking? So I just put that in there. It's not to like intimidate anyone. I put in some studies here. Just these are like the big ones, or things that are like that can get you off the ground if you're learning, mechanical ventilation in the sense of like ARDS and like setting low total volume settings and that stuff. And this isn't, meant to be like, this isn't at all meant to be like an exhaustive list. It's just like somewhere to start. All right, so this was quick intro to something profound. Still waiting for Nick. I've noticed some patients ventilating fine with a PIP of like 20, 22, suddenly hits 40 randomly. So that could be a couple things, honestly. So number one is if the patient has like intermittent work of breathing, if they're like, I've tried disconnector with bronchospasm either. Yeah. So like bronchospasm is one. The other thing is if the patient's like intermittently pulling down the circuit. So imagine if you're have some volume and the patient is like sucking down the circuit, right? If it's in volume control. As they suck harder and harder, the peak area pressure is going to go down because as the vent delivers a volume, there's sort of a certain amount of flow that's in the circuit that is the volume, right? So as they suck down harder and harder, they're going to pull more flow out of the circuit. Ergo, the circuit's going to depressurize. So in that situation, it might be 20 or 21, right? And I would need to see like sort of the waveform to like further kind of like evaluate what you're talking about. But if on the next breath, they're not pulling down hard, and let's say they have auto PEEP maybe, on the next breath, when the vent goes to deliver a breath, it might need to pressurize higher to get that breath in. So that would be one. The other thing is depending on where it is in the I time could be, yeah, I was just about to say that. So Josh pointed out the I time. So depending on where it is in the breath cycle, so if it's towards the end, if the patient, starts to blow out against the circuit before it's done with the inspiratory time, the vent's going to recognize that pressure, but it's not from the vent side, right? It's the patient like blowing out against the vent, trying to get it to cycle. So it's this like delayed cycling. So the pressure might be higher. If it was, if we're having sort of, I would definitely do what you did, which is like check for bronchospasm, check for mucus plug, check for atelectasis, check for like pneumothorax, et cetera, et cetera. If those things were all like negative, I would, look to see if it was like a synchrony issue. So either like delayed cycling, or if they're intermittently working to breathe. So like a flow starvation situation. That's what I would think. Okay. KRH, that's a cool name. So the delta is the inspiratory pressure above the PEEP. Yes. There's many names for this. Unfortunately, it's like super duper confusing. It's like delta pressure, inspiratory pressure. Some people call it driving pressure, pressure above PEEP, pressure support, right? It's technically pressure support. All those names. I try to delineate as much as I can and just say, pressure above PEEP is the inspiratory pressure. The thing that you have to recognize is that the total pressure is the PEEP plus the inspiratory pressure. So 5 at PEEP plus 10 of inspiratory pressure. So your total is 15, 5 plus 10. Okay. Okay. We have a YouTube comment. Constantly have battle over my preference using pressure over adaptive PRVC. Biggest reason I hear cognitive offload and why would I want to have to keep track of the VTEs? Constantly have the battle for my preference over. The biggest reason I hear is cognitive offload. Okay. So, I don't think it offloads us cognitively, to be honest with you. I think that's dangerous in a way, because when you give these adaptive modes more freedom to do what they want, the patient could be doing something, the vent's doing something, the patient's doing something, the vent's doing something, the patient doing something, the vent's doing something. And ultimately they can sort of like get, that's what I say back to them. Yeah. Ultimately they can they can be out of sync, like desynchronous. And at the worst, it could be causing, death and torture. So I don't think there's a cognitive offload, honestly. And I don't know if you were here for the whole thing, but remember, I would say back to whoever that you're not getting anything more with, let me put this a different way. Only with volume control with constant flow is there a pressure differential. Number one. Number two is even if you had decelerating flow, if, the compliance got better, it's not like the peak area pressure is going to go down, right? Like, it's not like the peak area pressure is going to not go down. The vent's going to recognize that it needs less pressure to deliver the volume. So I just don't I don't know if I really buy this cognitive offload, less peak area pressure, that thing. I don't know the study off the top of my head. It's from 1999. I think it's in critical care medicine. That was the study that said peak area pressure, is lower with PRVC, these adaptive modes. But it was only 4 centimeters of water, and it was versus volume control with constant flow. So if you're already using a decelerating ramp, it doesn't apply, which is, so now all you have is just the issues with PRVC, which is the desynchrony. Now, if your patient's paralyzed or there's some, trach person and they're stable or whatever, and they want to do PRVC, have at it. But if you have someone with ARDS or metabolic acidosis or asthma or something, I don't think it offloads any cognitive. I don't think it offloads you cognitively. If anything, it makes you complacent, and you'll do less checking because you think the vent's doing all this stuff, and then the patient could be ultimately getting hurt. Going from Revel to Hamilton, scary how people don't understand their ventilator. Yeah, you tell me. I agree. All right, my friends. Any last questions? Paramedic student, good resource, understanding vents. Me? No, I'm kidding. Honestly, there's not a bunch of good stuff. No, I like the Essentials of Mechanical Ventilation book from Hess, not paid endorsement. I like that book overall. The CEVA vent course out of Cleveland Clinic is very extensive. It's a little intimidating at first, I think. I think starting with a ventilator textbook. So the Hess one is good. I think it breaks it down pretty well. It's easy to read. It's it's an easy read book. I would start there and do as much as you can. Someone from YouTube said Oak's ventilator management is great. Okay, so Oak's, I guess I haven't read that one yet. I am working on a vent book, not to sort of plug myself, but I understand there's not a great resource anywhere, and that's sort of I'm working on that at this moment. So hopefully that'll be something I can sort of give you guys. If you're a paramedic student, Hamilton has a nice vent simulator on Apple, I think. You can download it and like set it up and like you can have like different scenarios and like what you should do. So if you sort of like learn by doing, I would do that for sure. And then this other sim that I use, which is called it's vensim.cc, which is made by a doc out in University of Minnesota. It's a really easy to use sim and just to sort of like get comfortable with the waveforms. All right, Josh says I have quite a few patients recently with suspected brain injuries who want to pull large volumes on long eye times, even with low CO2s. They do this. Is this common? I think it is common with head injury. Certainly with I forget what it's called. With cervical spinal cord injury, there is a protocol to like do really high total volumes because otherwise patients feel like they can't breathe. So it's sort of like to really move the chest to get like to have some tactile feedback that they are breathing. But I do think that's common. I do see that sometimes as well. Definitely if there's any degree of like neurostorming, which like me and Casey did a video on before, if they actually have neurostorming, not just like fake neurostorming. And honestly, I don't think there's like anything really good. There's like not a good like fix for that, right? You just have to like sort of fix the underlying condition, unfortunately. Let's see here. Yep, you got it, dude. Rocky Mountain Protocol. I don't know. Is that what it's called? Sounds like a cool name. I think it's like a Michigan protocol or something, but maybe it's the Rocky Mountains. I'm not sure. I thought the Rocky Mountains would be more rockier. All right. Going once, going twice, my friends. As always, appreciate the time, appreciate the effort. Yeah, dude, you got it. Everyone's got it. We'll try to do these maybe more often. All right, cool. Thanks, guys. And thank you to my YouTube friends. I'll be uploading this at some point, maybe like the next day or two or something. So, okay, cool.